Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today we've got another Q&A, Pat.
Here we go.
I love it. And I'm really happy to see that my voice has returned because this morning I woke up.
Wasn't a good start, was it?
Wasn't a good start. Hello, Dr. Pat. So anyway.
You don't call me Dr. Pat at home.
No, don't give that up. I think the listeners would like to know that I call you Dr. Pat.
All right, yes you do.
Yeah,
yes, you do.
I really don't. All right, so we're going to get stuck straight into it because we've got some rippers and it's been a minute since we've done a Q&A, so let's go.
Good, I like this.
Hi, I'm Lauren. I'm 18 weeks pregnant with my first, and my mum has been telling me that I shouldn't get my hopes up for a vaginal birth because when she was pregnant, she was told she had a very long cervix and there was no way she would ever labour and deliver naturally. My sister also has this, and I think a previous ultrasound of mine mentioned that I have a long cervix as well. So is what my mum's doctor said all those years ago accurate, or is there reason to hope that a vaginal birth is still possible? Thanks.
Is that just the only predictor, like a long cervix?
I don't think having a long cervix is much of a predictor of anything, to be honest. There are wide variations in normal reproductive anatomy. And I think this is one of those ones where we could pretty safely put this in the basket of family folklore. And this is surprisingly common and often not backed by any contemporary understanding of how things work with obstetrics. And sometimes even it's not the mum, it's the grandmother or the great-grandmother. And the story is told with a great deal of authority that this is part of our family's health history. And it's very difficult to weave. There's so much missing from the original story that it's very difficult to even know exactly what was being described. Yeah. And, I'm not saying that it's worthless information. I'm just saying that really it's not a predictor of how things will go on this occasion. So if we look at this situation, my mother used to have this expression called smile and nod, and lots of information that we're given by non-expert people needs to be put into the smile, thank you for your interest in my health, nod politely and move on. Yeah.
Because we don't, like in this listener's question, we don't know whether that obstetrician told her mum that and she never got a chance to labour.
Yes, see, back in the day they were a bit more likely to do that on some occasions. Some people were just thought to be bad prospects. And what they were trying to do back in the day, with absolutely zero success, was identify women who were likely to obstruct in labour. And then you might have been able to say to that person, you're going to obstruct in labour, don't even try. And that's where things like pelvimetry came in, where they would take an X-ray and measure how big the baby's head was and measure how wide the woman's pelvic inlet was and say, nope, this will never work. And the only problem with most of these theories is they didn't work. And they didn't allow for the very, very dynamic changes that happen in labour. Pelvis stretches a bit, head squishes a lot, baby's head squishes a lot, and that's a dynamic process which was practically impossible to predict. So people were told, no, you definitely need a caesarean section, and then they'd come into labour in the middle of the night, the baby'd come out and everyone would go, well, that wasn't supposed to be possible. So a more modern approach to obstetrics, of course, is that with very few exceptions, we start at the starting line, we monitor labour carefully, and we see how it goes. But it really is not something that can be accurately predicted how an individual person would go. And there are some family histories that are relevant, like your risk of gestational diabetes, for example. Lots of genes involved in that. And if your mother had bad gestational diabetes on big doses of insulin and wound up being induced and having a section, that's a relevant family history. But mum had a long cervix. I'm sure there's countless millions of people in the history of the world who've had long cervix who've laboured just fine.
And I reckon this is really good for people who perhaps, it's not their issue, but what everybody's issue is we all go into pregnancy and birth with a belief system.
Yes.
So just to take a minute and look at that belief system, maybe do some journaling, whatever, see what is in your subconscious about what you believe about birth.
Yes, because we shouldn't be looking for obstacles before they even happen. Yeah, I think everyone comes into, with very, very few exceptions, people come into that first late pregnancy, labour and delivery with a clean slate. And there are some technical obstetric reasons why some special people shouldn't attempt labour. But if it's something that could have 1,000 explanations, like my mother needed a section, I was personally born by caesarean section, not predictable enough, not nearly predictable enough for you to say, I'm going to go down the same path. Not at all. Yeah.
Good luck. I hope you can get to the nub of that and then just believe in your body and believe in the process.
Yeah, so that history is definitely one to discuss with your care providers, but I would suggest not get too worried about.
Yeah, good. Alrighty, Patty, let's go to this one.
Hi, Bridget and Pat. This is Jamie and I'm a third-time mum. I'm 36 weeks pregnant and have been listening to you guys for all 3 pregnancies now. I have 2 questions around birthing of the placenta. The first is just generally what are the pros and cons of each of the options available to women. My experience has been that active management is very much what's pushed and wondering what the rationale behind that is. The second part of my question, and more what brought me here, is in the context of my last birth. Was completely natural. I did have a small fragment of retained placenta that passed on its own a few days after birth without any infection or bleeding complications. But because of this history, an option that has been presented to me this time is to have a Pitocin infusion for 4 hours to prevent PPH. In looking for all the information out there, there's a lot on treatment of PPH, but not so much around using this drug as a preventative, and I'm just wondering if this is actually best practice. And again, just keen to know the pros and cons of having the infusion versus not having it. Interested to know your thoughts. Thank you.
Now, potentially, Jamie's had her baby.
Already?
Yeah, so
okay.
We'd love to know what happened.
We could sneak forward and find out.
Yeah.
Look, terrific question and dear to my heart. And I think this gets to the heart of one of the really important issues in obstetric care in the developed world, and that is, what's obstetric care for? Are we, and I say that honestly and truly as somebody who doesn't know the answer sometimes, and who is honestly asking, there's no hidden agenda, are we as obstetric care providers there to do every single thing we can to prevent a problem, or are we there to come in and fix a problem when it's already happened? And this is that question is probably at the heart of the various disputes that happen in the world of obstetrics about excessive intervention, because there are some interventions that your obstetric care provider probably think is a no-brainer, and other people say, well, hang on a minute, can't I just have that problem X, Y, Z, not prevent it, but just treat it if it happens? Yeah.
I've heard you talk about this as, are obstetricians the ambulance at the bottom of a hill?
Yes. Are we the seatbelt?
Yeah.
Or the ambulance at the bottom of the cliff? Yeah. So I think if we look at this particular issue of postpartum hemorrhage, we've got to go back in time. Historically, there wasn't a lot done to prevent it. And when it happened, the horse had bolted, the hemorrhage was happening. As the hemorrhage got larger in volume, the woman's blood system was less able to clot, and you got to a point where it couldn't be fixed. And countless lives have been lost over the history of humankind from postpartum hemorrhage. In more recent centuries, with the application of scientific methods to something as age-old as childbirth, we've got a bit better at prevention. And this is still a red-hot issue in the developing world, where somebody might be labouring a day's travel away from a hospital. So the question was, to do with active or preventative management of the third stage of labour and preventive management of postpartum hemorrhage being something that's, I think the word used was pushed. I hope it's not pushed on anybody. I hope it's encouraged. And I think that what that means. What we mean by that is we, as your obstetric care provider, would much rather prevent a postpartum hemorrhage than be called up to deal with one. Yeah. Preventing one is a bit like vaccination. You have to treat tons of people to save the few that are going to happen, because you can't predict who's going to get the problem, give or take. Everybody is at some risk of postpartum hemorrhage, and that's the problem. So what's the prevention? There's a standard advice given to people that when the babies come out, that we should give a injection to help the uterus contract, the placenta disengage, and the placenta come out quickly. And that will prevent a very, very large percentage of so-called atonic PPHs, where the uterus is too relaxed, it can't contract properly because the placenta's still inside, and bleeding can happen. And there's no doubt that works on a public health level. If you look across the community, that works very nicely. Not everybody wants that intervention, and I think obviously we should respect that, but it's probably a good idea for us to be aware historically of where it sits, and why it's recommended. For people who don't necessarily want that intervention for whatever reason, there's sort of three options. You could have an injection, you could do nothing at all, or you could do other things that help the placenta come out promptly, including rubbing the uterus. And I think people's choices should be respected, but I also think it's wise that people have the information that underlies the advice.
So she's got two things that are a bit different. Like, she had a little bit of retained placenta last time. Does that make her more susceptible to a PPH in a third birth?
Yes, and that was the second part of the question, and that's really interesting because that's different. The first one is like a public health intervention where we're proposing doing it to everybody or everybody who wants it, to protect a small number of unknown people who are going to get outcome X, Y, Z. And the second one is a bit like secondary prevention, where we know that woman is at higher risk than everybody else, so the advice we give her might be different again. And in somebody who's had a bit of retained placenta, if that's caused a significant postpartum hemorrhage, then we might identify that as somebody who is at additional or elevated risk of getting a postpartum hemorrhage next time, and say, not only do we want to give you the injection, but we're thinking of giving you other treatment as well to prevent that postpartum hemorrhage, because we think you're at higher risk because it happened to you in the past.
This is a very basic question, but she said that the infusion would happen 4 hours before the birth?
No, from when the baby's out, put the infusion up and run it for the next 4 hours.
Yeah, right.
So there are lots of things that can be done to help prevent postpartum hemorrhage, that other than just the injection you get in your thigh. There's also infusions that can be run over 4 hours. There's a different version of the injection in your thigh that is a long-acting version of that drug. There's a drug called misoprostol, which can be given as tablets in your bottom. And then there's rubbing the fundus to help it contract, rubbing the uterus to help it contract to expel the placenta. And sometimes if someone's had a history of a very severe postpartum hemorrhage, a couple of litres, they were in danger, they had a blood transfusion, it was all very dramatic, the next time that woman has a baby, it might be recommended to her that she has 1 or 2 or 3 or all of those things given preventatively. Yeah. Now, we're not proposing doing that for everybody. We're proposing doing that for that one special person who's shown a tendency towards severe postpartum hemorrhage in the past.
And Jamie used the word Pitocin, but that sounds American, doesn't it?
Yeah, so that's commonly called syntocinon in Australia.
Yeah, good. All right, well, Jamie, if you've had your baby, please tell us.
We'd love to know.
Yeah.
We'd love to know. But terrific question. I mean, it brings up some really core issues in obstetrics. So what are we here for? If you ask any obstetrician or trainee obstetrician, they would say, I'd much rather do something to prevent a problem than to try and rescue it once it's underway.
Hello, Dr. Pat and Brigid. I've just listened to your episode on stored labour, and I just wanted to send a question about my second pregnancy. I'm currently pregnant with my second baby. My first daughter is 2, and I'm currently 12 weeks along this time. With my daughter, my labour was 36 hours from waters breaking and contractions starting straight away. And I feel like I did all the right things. I did all the moving around. I got in and out of the shower, in and out of the bath, on and off the birthing ball, lots and lots of moving around. But it still feels like it went on for just a bit too long. And I ended up with an epidural at 9 centimetres because I was just too tired and I wouldn't have been able to push. And then I had a vacuum delivery with a episiotomy and tore upwards. And I just wanted to know if there's something I can do this time to make my labour go a bit quicker, or should it naturally go quicker, it being my second baby? I don't think there's anything else I could have done. In hindsight, I felt really educated. I had a really good birth plan with, my obstetrician was very happy that it was accept and help as and when I needed it, but it was also well educated. So yes, I just wanted to know if there's anything else you can recommend going into a next labour to make it go a bit faster. Thank you.
Is 36 hours is a bit outside the average time, isn't it?
Yes, it's very long. We have to remember that not everybody's talking about the same thing when they're talking about the length of labour. But to have a painful labour that goes for 36 hours is a long time.
It's a long time, and it's a long time to keep your strength up, be resilient, keep your mind on the job.
Yeah. So it sounds to me like that was a long and difficult labour, but it also sounds to me like this was a well-prepared person who understood that it was going for a long time, that labours that go for that long can correlate with poor outcomes, and that some judicious, careful use of intervention was called for, and it went well. So epidural at 9 centimetres, late in the process, but we don't know. But let's say, for example, we weren't that keen on having an epidural, but we got to the point where one was useful. That may have helped relax the situation, get out to fully dilated. A vacuum was recommended. Sounds like it was well performed. This is first baby obstetric care in the developed world. That's not an uncommon outcome, and appears is common when a vacuum is done on a woman having her first baby. Some extension of the tear, I hope expertly repaired. That is a pretty common first baby story. Now the question is great because we're saying what can be done. It's very, very likely statistically to go much better the second time around, no matter what you do, which is great news.
Yeah, and if you want to see that visually, you've got an English accent, so I'm not sure where you're calling from, but the Australian stats, if you just go to the Australian birth stats, you can compare first and second births and labours.
Yep.
And it's kind of chalk and cheese.
They are very, very different. Yeah, very different. So the bit that works better in second and subsequent labours is the active part of the labour. And so we so often see somebody get to about 4 or 5 centimetres in a first vaginal birth, and even if it's going well, it's slow. It's a slow process. It really hurts. So intervention for that can happen, but even normal progress, it takes a long time. Then second and subsequent is different. Things work a lot more efficiently. You get to 4 or 5 centimetres, the intensity picks right up, but rather there being 7 hours to go, there might be 1 hour to go. And that is actually, I hesitate to say it hurts less. I don't think it does hurt less. I think it hurts the same amount but for less time.
Yeah.
And so by the time somebody gets to like last time, several hours went by and you'd got to 9 centimetres and you had an epi and some assistance with the vacuum. By the time the woman having her second baby gets to the point where it's an hour or two in the intense active part of labour, she's not putting up her hand for an epidural and a vacuum. She's holding a baby.
Yeah.
It's out. It's done. And it really is very different. From the obstetrician's point of view, we have a mind on progress. And we would be not worried at all about a woman who hadn't had her baby 4 hours after being thought to be 4 centimetres. But we would be somewhat concerned about someone who hadn't had a baby if it was her second or third, and she was thought to be 4, and 4 hours later the baby wasn't out. So that's the other way of looking at it. The progress should be better.
Yeah.
And when it's not, the good obstetrician will be thinking, well, why not?
Yeah.
Am I missing something here?
Yeah.
Because that woman should have that baby in her arms by now.
Yeah.
Yeah.
All right, good luck. At 12 weeks, I hope your pregnancy goes along really smoothly and you have a labour that's a little bit shorter, but I'd like to congratulate you on your strength and your resilience during your first. Well done.
Absolutely.
Yeah. I think we've got time for one more.
Hi, Dr. Pat and Brigid. My name is Katie, and I'm calling from the United States in Kansas. I'm pregnant with my 4th baby. I just started my 3rd trimester. And my question is about irritable uterus. So with my 3rd pregnancy in my 3rd trimester, I had this, and it was something that I had never heard of and never knew could be a thing. I had severe cramping and pain that felt like contractions. They were regular, and they lasted for several hours. So I went into the doctor's office, and they put me on a monitor and could tell that they were indeed contractions, but they were not dilating my uterus. It hurt a lot. They gave me some medicine that made me drowsy, and it did stop the contractions or whatever was going on. So I was just kind of curious, is this something that can be prevented in this pregnancy, my 4th pregnancy, and what causes it? Is it something that we know the answer to? Would love to know more about it and see if you have any suggestions. Thanks.
That would be so kind of, I'm not belittling it, but super annoying.
It's super annoying, distressing, irritating, and a reasonably common problem. So terrific call to bring it up here. We don't know what causes this, and it's such a problem because the approach that your obstetric team, your caregivers are going to take is a reverse one, where we're going to look at irritable uterus as a diagnosis of exclusion. And by that we mean we're going to rule out all the dangerous stuff that might be causing your uterus to do that. So vaginal infections, major problems with the pregnancy itself that can be looked at on ultrasound, and urinary tract infection. And more often than not, we don't find those things, okay, because they're the treatable causes. And we could say, oh, well, you've got a UTI and the bladder's right next to the uterus and your bladder's inflamed and that's upsetting the uterus. Let's treat your UTI. Well, it'd be nice if that happened every time because that's a pretty straightforward thing to do. But often the urine will be normal and the vaginal swab will be normal and the ultrasound will be normal. And yet the uterus is constantly sitting there in a state of excitation. It's we call it irritable. It's easily provoked to contract, but they are not the sort of contractions that cause the cervix to dilate and labour to start. So what's the problem? The problem is they still hurt. It hurts. So what's the treat? The investigation is to rule out reversible causes, and the treatment is to treat the pain and avoid, if possible, things that cause the uterus to start to do that. And sometimes people will have identified something, some sort of activity that sets it off. rest but not too much rest. So you get the idea that we don't know exactly what causes it.
And she's got 3 kids, so I don't think there's tons of rest happening.
Yeah. So, if I was an obstetrician in Kansas at looking after this patient, I would be saying, look, we've thoroughly investigated this for reversible causes. There's a role for pain relief and prevention. The caller asked about prevention. I don't think so. So it's hard to recommend evidence-based prevention when we don't know what the cause is in the first place.
Look, how hard would that be to research that? I mean, kind of impossible.
It could be. It could be very, very difficult to get a cohort together to really understand what is going on here. There's a wide range of normal phenomenon in pregnancy which can be very difficult for people, but are not highly pathological. Yeah.
And I think that's a bit of a problem because it's not pathological, but it's certainly difficult for the woman to manage. And I think this is the complaint a lot about women's health.
Yeah, it's easy for your caregiver to say there's nothing serious wrong with you, but they're not the one with the pain.
Yeah, they're not the one with the pain, and they're not the one at home trying to look after 3 kids.
Yes, yes. So that old-fashioned heading of supportive care, treating the pain, giving someone with a significant irritable uterus problem the attention that the problem deserves, even if we don't find any, at the end of the day, any very significant or serious pathology. And it can still be difficult to experience.
Yeah. And well done for calling in, because what actually happens, even if there isn't a sort of medical treatment or medical understanding of why that happens, what you've done by calling in is alerted this as an issue to other people that listen to this show. And the more understanding around things such as, irritable uterus during pregnancy, then next time you explain to a friend or whatever, like, this is what's happening, she'll be able to go, oh, yeah, God, that sounds terrible.
Yeah, exactly. Yeah. I think irritable uterus has got a bad name. It sounds like the uterus is cranky.
Yeah.
If it had a better name, it might get across to the people around you that this is actually something that, from your point of view, may not be highly pathological, but is still very difficult to live with.
Yep, good. People, that's all we've got time for.
Good. Really good callers today.
Yeah.
I like that we've got a listener in Kansas. That pleases me a lot.
All right, everyone. I hope that's been useful for everyone. There's a lot of generalisable information there for anyone that's going through their pregnancy. I bet there's some there that go, oh, God, that's happening to me too. So thank you for those callers sharing their stories with us. All right, until next week, Patty.
We'll see you again next time.
Yeah, thanks a lot for listening, everyone. Bye for now.
Bye.
Even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.